All right, I think we're going to go ahead and get ourselves started here today since we have plenty to cover. And again, as if you're just joining us, please feel free to introduce yourselves in the chat. It's always good to kind of make those connections, and we're hoping to develop a more of a network of psychiatric care providers across the U.S. by bringing us all together here once a month. So we'll talk a little bit more about that in a second. In the meantime, my name is Maria Monroe DeVita, and I'm one of the core faculty members for the Northwest Mental Health Technology Transfer Center, or MHTTC. And welcome to today's webinar, which will focus on cardiovascular health for individuals with serious mental illness. We're excited to have Dr. Martha Ward with us. This is the third webinar in a series of 4 that focuses on topics related to the role of ACT psychiatric care providers. First, I just wanted to give you a brief overview of our network. The MHTTC network is a nationwide network that is supported by SAMHSA, and our network includes 10 regional centers and a network coordinating office. There are also networks for addiction and prevention using the same structure. And we support resource development and dissemination, training, and workforce development for the mental health field. And then our Northwest MHTTC out of the University of Washington covers Health and Human Services Region 10, which includes Alaska, Idaho, Oregon, and Washington. And our goals are to accelerate the adoption and implementation of mental health related evidence-based practices, heighten awareness, knowledge, and skills of the workforce, foster alliances, and address training needs among diverse partners, and ensure availability and delivery of free, publicly available training and technical assistance. And sorry, there is a car alarm going off down on the street near my office, so I apologize if that is interfering with my talk here. Our core area of focus for our particular center is on evidence-based practices for serious mental health issues such as psychosis. But we do provide a lot of other training and support in a number of different areas such as suicide prevention and diversity and equity issues, school mental health, among others. So today we're going to send out a link to the webinar recording and the slides, as well as a certificate of attendance within a couple of weeks of today. If you could please just use the chat for any technical issues or, greeting your colleagues on here, or if you just wanted to make a comment. But if you have any questions that you want us to address, put that into the Q&A. It's much more easily tracked, and the comments kind of get lost if you put them in the chat. So please use the Q&A. You can do that at any time, but we won't get to it until the very end of Dr. Ward's presentation today. Another alternative is you can raise your hand, and then you can unmute yourself to speak if you wanted to pose your question. But again, this will be at the end of Dr. Ward's presentation. We won't be facilitating any questions during her presentation today. The other option too is after Dr. Ward is done, we're hoping to have about 30 minutes or so where folks can also just bring up general questions related to your role as an ACT psychiatric care provider. So that during that open mic time, again, we encourage you to raise your hand and we can have a little more discussion face to face rather than having to just use the Q&A box for facilitating questions. And then at the very end, we'll have an evaluation for you all. It really helps us to kind of guide our future efforts in this area. So stay tuned for that. And here's just a link to some of our websites and resources, including our series. And I introduced myself, so I just want to make sure that my co-facilitators here, Steve and Ann, can introduce themselves as well. Go ahead, Steve and Ann.
Okay, yeah. Hi, I'm Steve Harker. I'm a psychiatrist on a forensic ACT team in St. Paul, Minnesota. I guess I started doing ACT in my residency in Madison, Wisconsin, in 1997. And then in Minnesota, they started ACT in 2005. So I've been doing it since then. I'm interested in fidelity to the model, and I'm trained to do the Team ACT fidelity reviews. And I think the favorite part of my job is teaching psychiatric residents. There's a local program in town, Hennepin Region Psychiatry Residency Program, who place third-year residents all on ACT rotations for a day a week in their third year, and I kind of facilitate that. So very excited to be here today.
And I'm Ann Hackman. I, like Steve, started working as an ACT psychiatrist during my residency and have been with the ACT team at the University of Maryland in urban Baltimore for the last 31 years. I concur with Steve that teaching is great, and my favorite thing to do is take trainees, medical students, residents, occasionally other professional students on home visits and show them just how amazing that is and how you can learn things in the first 30 seconds in someone's home that you might never learn in another setting. So appreciate being here and looking forward to this talk.
Thanks, Steve and Ann, and you all can see why we asked them to be our co-facilitators, given your dedication to not only the work on an ACT team, but also continuing education and training of others. So let's also now turn to a quick poll of participants. I know we asked you to, if you could introduce yourselves in the chat, which is great to get kind of some familiar names and faces, but we're hoping that you can also complete just a quick poll that should show up right in front of you. We wanted to just get a sense of kind of how many people are actually working as a psychiatrist or a nurse practitioner or PA or psychiatry resident within ACT teams. And then how many of you are here today because you want to know more about this topic, but you're not necessarily an ACT psychiatric care provider? So I'm going to just give you just a couple more seconds here before I will end the poll, just to get a sense. It's always good to know who our audience is. Okay, and so it looks like today we have about 42% are not psychiatric care providers, and then our next highest percentage is nurse practitioners, and then psychiatrists, another almost 20%, and then we've got 3 physician assistants on with us today. So good to know, and I think helpful, I think, for Martha as she's presenting to the group today, and in terms of if we've got some non-technical questions that may come up too that are focused, based on those of you who are not necessarily doing this work as a provider. Let's see, I think, Anne, were you going to talk a little bit about the series?
Absolutely. So this is part of a continuing series of monthly calls for ACT prescribers offered in collaboration with the Institute for Best Practices at the University of North Carolina. You obviously have already figured out how to register or you wouldn't be here, but you should be aware that the 2 prior sessions are available to you online. Steve and I did the first one around what makes ACT psychiatry the best job on the planet. And he and I firmly believe in that. There was a wonderful one last month with Dr. Ward's colleague, Dr. Robert Cotes, on the pharmacological considerations for ACT team prescribers, particularly around clozapine and long-acting injectable antipsychotics. You already know what you're here for today, for cardiovascular health for individuals with serious mental illness. And we have another one coming up on August the 15th, updating substance use disorder care in the age of fentanyl and stimulants, implementation of harm reduction and treatment. And that's coming up next month. So we hope that you'll go back and listen to some of the previously done sessions if you weren't able to join at the time, and that you will be here on August the 15th to join us again.
Thanks, Anne, and my apologies to any of you who are from Washington State, because we will all be together, hopefully in person on that same day, doing our statewide meeting together with our nurses and our psychiatric care providers, but we will make sure that everybody gets access to the recording afterwards. All right, so I think I'm going to turn it over to Steve to introduce Dr. Ward.
Yeah, and I just met Dr. Ward today before this talk, and she's already answered one question I had about some stuff, so I'm really looking forward to it. Dr. Ward works out of Emory University and works in she's dually boarded in internal medicine and psychiatry, and works in a primary care clinic that focuses on SPMI. And some of those people are, I guess, on a local ACT team. And so she's hoping to go over risk factors that contribute to increased rates of cardiovascular disease in this population, and wants to also talk about principles of motivational interviewing. She's actually asking if you guys could keep in mind a happy volunteer to be a ambivalent cardiovascular patient, because she would like to do some demonstrations with a person around motivational interviewing. So if that's something that you're interested in, when that time comes, just volunteer. It looks like she's going to go over diagnosing obesity, hypertension, diabetes, dyslipidemia, and trying to increase familiarity and comfort with us prescribing medication for these risk-associated conditions. Yeah.
Thank you for the introduction. I'm going to go ahead and share my screen so I can get my slides going for you all. All right. And, okay. So as Steve was saying, I'm Martha Ward and I live in Atlanta, Georgia. And I had the pleasure of, during residency, I did my residency at Emory, so also in Atlanta. I spent some time with ACT teams on elective rotations because community health and community psychiatry is something that I'm really passionate about. My last rotation, when I was trying to decide between like doing ACT care or doing primary care for patients with mental illness, I was pregnant with my daughter, who's now 13. And it was summer in Atlanta, and it was probably like in the hundreds roughly. And we were visiting a lot of people's houses. There was a lot of air thick with like congealed grease smoke and cigarettes, and a lot of cockroaches, a lot of people sweating and not wearing shirts. And I was like nauseated the entire time. And I just want to say, you learn a lot going into people's houses. And definitely, I admire you all. And thank you for the work you do. A lot of this talk is focused on prescribers and non-prescribers alike, because I think there's a lot that we can do to move the needle on cardiovascular health in our patients who suffer from severe mental illnesses without necessarily prescribing a specific antihypertensive for them. So a lot of my talk is going to focus on that. I don't have any financial disclosures. I do have a chapter in Up to Date. Actually, I guess I do have a financial disclosure that's on this topic, and I used some of the information from that to inform some of what I've talked about here. And I've received some payments in the past for presenting some of this data, but I don't have any financial contributions from any specific journals or corporations or medications. So just to get that out there. I will say my caveat, however, is that I'm in Atlanta. Or evening or afternoon thunderstorms have rolled in at 3 p.m. here. So I hope there won't be any connectivity problems, but I do have these two animals who live in my home. I'm working from home today. Owen and Ellie hate the rain, and they also hate the post-delivery person. So if you hear them barking in the background, I apologize. And with that, let's jump right in. Okay, so unfortunately, cardiovascular disease and serious mental illness are best friends. They go hand in hand. And when I say that, I mean there's a lot of comorbidity on both sides of the equation. When we look at individuals with schizophrenia, they're 64% greater prevalence of cardiovascular disease than in the general population. People who suffer from depression, that's 63% more. CVD, and for people who are diagnosed with bipolar disorder, there's a 1.5 to 2.5 times risk of contracting cardiovascular disease than in those people without. So unfortunately, this results in a lot of morbidity as well as mortality. We know that there's a mortality gap of somewhere between 15 and 25 years for people with serious mental illness who are treated in the public sector. It's a little bit lower than those treated in the private. I mean, that is a little bit higher than those treated in the private sector. And we do know that the majority of this mortality is due to cardiovascular disease. There's a lot of reasons for this, and this is a little bit of a busy slide, but I'm hoping that through the course of the next 45, 50 minutes or so, we can walk through a lot of this. There are a number of input factors that at baseline lead to increased risk of cardiovascular risk and cardiovascular disease. Biological and genetic challenges, chronic inflammation is increasingly seen to play a part. Behavioral cues, which we'll discuss extensively, pharmacology, there are psychological components as well in terms of optimism and the importance of social networks and social support. And then clearly these comorbid illnesses like hypertension, diabetes, hyperlipidemia, the metabolic syndrome, smoking, obesity, sedentary lifestyle, these can lead to cardiovascular disease, which then leads to excess cardiovascular mortality. We can see at the top here over and over is the influence of disparities in care access and quality. That is one of the biggest goals of my career, is to one patient at a time, and hopefully in the population I treat here in Atlanta, to change that disparity in care, access and quality. We could talk about that for a long time in terms of even patients who do see primary care providers, the difference in terms of referrals for even basic age-appropriate cancer screening. And it really starts with a decreased recognition, diagnosis, access to care. And so hopefully we can all do something to change that. Okay, so I'm going to focus, as I said, on potential areas where we can intervene. And the first one we're going to talk about a little, probably this will be, I would say at least a third of my talk is on changing behavior, which is a hard thing in everyone. There are a lot of opportunities for addressing cardiovascular risk factors that are associated with behaviors that our patients have. So poor diet, I put the honey bun there. I don't know if your patients are eating the honey bun. The honey bun is like a big part of life for the patients that I treat. I don't know why. It was used as like a economy of exchange in the inpatient psychiatric unit where I worked in medical school and in residency. A token economy, that's what I was looking for. Sedentary lifestyle and tobacco use. And we'll touch on each of these fairly briefly. But before we go into that, I wanted to talk just a little bit about motivational interviewing. Probably a lot of you have some familiarity with this, either through formal training, through reading, or through just some of the principles that you live your life by. So motivational interviewing is very much a person-centered method to help people to understand what their motivations are, to change. And really what it means to do is to allow the provider, the person who's in that position of relative power in the relationship, to take a seat and not be directive, to say, okay, well, let's think about this together. Open up your experience for me and tell me what are the ways that you feel about this, and then helping that person to tip the scales from ambivalence and not wanting to do a certain behavior to doing more healthy behaviors. So really encouraging the intrinsic motivations that our patients have. It's not necessarily like rules, it's more just a way of being, and it helps everyone, not just our patients, because they're often people who have had challenges with others telling them what to do throughout life, because of challenges with at least the patients that I treat with strict parenting or institutionalization, or encounters with law enforcement that are very punitive. And so it allows you to take the focus off of a specific outcome and think more about, where is my patient right now and how can I help them to realize their ultimate goals for health and well-being. There are certain ways that questions are posed in the spirit of motivational interviewing. That's really a lot of acceptance, compassion, collaboration. These are obviously things that most ACT providers come to this job with as guiding principles already. So questions and conversations should really be very open-ended, instead of, you want to quit smoking, right? It's more like, tell me a little, what's going on with your cigarette smoking? Tell me a little bit more about what's going on with that. Affirmations are often used. So anything that is a positive experience for the patient or health related in a positive way can be highlighted. I'm just as likely to highlight some of the benefits that patients perceive from non-healthy behaviors, just so that I can clarify what patients' experiences are, but also to reflect on what their experiences are and to help them feel heard. It also can pull you out of that kind of tug of war of, I said yes, I said no. I said yes, you said no. You know, just like, oh, so smoking helps you relax. Yeah, I can understand that. Summarizing often, again, so that you understand, but also that the patient knows they're being heard, and using summary to sometimes add new meaning to what a patient is saying. So like, yeah, I get it, that cigarettes are definitely helping you to relax, and that that seems like it's one of the main reasons that you on the one hand feel like it's going to be really hard to quit smoking, and then I also hear you that on the other hand you just can't stop coughing when you wake up in the morning, and you've noticed like it's harder to breathe when you're climbing up the stairs from the train. So that's a little bit more about what the concept of motivational interviewing is. The process, there's really 4 steps to it. The first is engaging the patient, and that's allowing the patient in a lot of ways to guide the discussion. And you all know very well that about patient engagement, it doesn't happen often in like one visit. And so a patient engagement might be going, you go into somebody's home and they're cooking and you notice they're cooking like French fries, like in boiling oil. And I don't know how much of this will relate directly to your patient population, but I'll speak from my personal experience working in the Deep South. So they're frying, something in oil in a way that could easily light fire in the house at any second. And, in addition to securing safety, you might say, oh, okay, again, getting into the affirmations. Oh, it's so great that you like to cook. Like, that's so wonderful. That saves money and it gives you so much more freedom. Is this one of your favorite things to eat? Tell me more about your favorite foods. Okay. And then, maybe the next time it's like, okay, well, tell me a little bit. Do you mind if I ask more about what other foods you like to eat, or what are your thoughts about the relationship between what you're eating and this recent gain in weight or this recent high blood pressure diagnosis? Excuse me. The next part is focusing. So of the things that we talked about, which one resonates with you the most? So we talked a little bit about how the food that you're eating today, that it might be contributing a little bit to your weight going up or contributing in some way to your weight going up. We also talked about how your blood pressure is higher. Is there one of those that seems more important to you today than the other? What should we talk about? Why? So figuring out why this matters. So what is the intrinsic motivation of the patient? And this can sometimes feel like a dance between not putting words into patients' mouths, particularly in patients that I have who have a lot of negative symptoms. Typically, you're going to ask a patient, a little bit more about, so you said you wanted to talk about your blood pressure. Tell me a little bit more about why you want to talk about that. Are there any things that any things that you can think about that would be different if you didn't have to have high blood pressure? Or you can be a little bit more directive and say, well, I know some health problems that can come if your blood pressure is high. Have you learned any of those things? And then again, asking, do you mind if I share some of those with you? Are you interested in learning a little bit more about those? Sometimes people will say no, and then you say, okay, that sounds good. And then you can change the topic, or you can say, another thing I was thinking about was taking medication and how hard that is to remember. Is that something you have a problem with? Or is that something you'd like to work on reducing? Things like this, or moving around, or looking at bigger goals in terms of wanting to complete life trajectory goals. I had a patient today who really was very disorganized, and he said that he just wanted to be able to do the things that people tell him to do. And I was like, oh, okay, well, how can I make that into something self-motivating? And we talked a little bit more about like what that meant to him in terms of living at home with his parents, and like, oh, maybe your parents wouldn't complain, and like they'd get off your back a little bit if you were able to, we were specifically talking about weight loss. And he could buy into that. So that was good. There's the final piece is evoking, and really what you're trying to do is move this dial between ambivalence or weight the scale towards wanting to change rather than wanting to sustain any particular behavior. The cost of change is really high, and there are always reasons why people want to keep doing what they're doing, even if it's extremely harmful. So it's important to suss that out, acknowledge it, and then to really use all of your abilities to shine a light, a bigger amplification on any time a patient uses change talk. There's all kinds of funny acronyms within the motivational interviewing lexicon. This one is darn cat, and this is types of change talk. So these are the things that you want to listen to and then amplify once you hear. So anytime a patient says something that indicates desire, like I'd really like to, I wish, ability, efficacy there. So I would, I can, I am able to, if their reason for motivation comes out, if they understand that there is some overwhelming need, if they are showing more of those active steps like commitment, I plan to, I will, that they're in that action mode, I'm going to do this today, tomorrow. And then definitely when your patients start to show some actual active steps towards completing their goals, that's a really good thing to highlight. And then the last part is planning. So the how, and there's a lot of emphasis on goal setting that is SMART. So that's specific, measurable, attainable, relevant, and time-based. The relevance and the attainability can be assessed sometimes through or the classic motivational interviewing literature recommends assessing these things on a scale of 1 to 10. A lot of, well, not a lot, but a number of my patients are like, I don't know what you're talking about, and can we stop using these numbers? But there's some data that shows that if you're, so you can say like how important this is to you on a scale of 1 to 10. And if something is less than like a 4, it's often seen that people aren't going to work on that goal, or if their confidence is rated on a 1 to 10, and if it's less than 4, it's unlikely that they feel that they have enough ability to complete the task. But it's also an opportunity to highlight some change talk. So to say, let me know, okay, so you're a 6, so tell me a little bit about why you're a 6 and not a 4. Like what factors help you to feel like you might be able to do this, or that this is really important for you. And then you can also use it to see what barriers they have, to say, okay, I hear you're a 6, but I'm wondering what's in the way of you getting to an 8 or a 9. And then to help alter the goal to be more attainable and more relevant if patients are lower on that scale. Okay, so some of the specifics about what is recommended regarding counseling patients for behavior change concerning these cardiovascular risk factors, and we'll go through diet, physical activity, and smoking. A lot of the data is based on mostly randomized controlled trials. So they're looking at, for the most part, cognitive behavioral therapy techniques that include some activity as well as some cognitive exercises. And these are, this is based on that, but this is also based on the evidence, but this is also based on just what I do like on a daily basis in my clinic. So a food diary can be extremely helpful because understanding what people actually are eating helps you to use to really dial in on those SMART goals. I found there's some validity to like asking about a 24-hour food diary, so you can get some information there, but really saying like, okay, write down everything you're eating, everything. This one doesn't even, it just has water. I'm like, what drinks are you drinking? Because it is always the drinks. That's the sneaky piece in my patient population. Sweet tea is like, got to keep asking about sweet tea because oh no, I don't have any drinks. We call them drinks here South. If they have sugar sweetened beverages or drinks. So yeah, no sweet tea, like there's not any. But yeah, having people write down exactly what they're eating, and it's just interesting. I love food. I love to eat. So it's like, for me, this gives me like a piece of what someone's existence feels like to some extent. Since you go into people's homes as well, you're able to like also just bring this diary, leave it in their house, and even like fill out that day with them or fill out whatever meal you came around that time, or have them show you groceries and say like, what are you planning to make, that sort of thing. It's important to understand where people are getting their meals. There's clearly a pretty big difference between this picture, which is from a shelter on the left, and then this is like Kris Jenner's refrigerator on the right. So the ingredients, like where you're getting your meals, makes a huge difference. It's important to know, as you do as an ACT team, like, is a patient going to like to shelter, like are they getting shelter meals? Do they live in a group home? Who prepares the food? Do they have the ability to make choices between different things? Do they plate their own food? A lot of these little pieces are going to help your clients, patients to make more realistic, attainable goals that are really, you know, small and proximal, that are actually things that they can attain. If your patient is able to shop for themselves, if they have access to a kitchen, where do you get your groceries? A lot of the patients that I treat live in areas of Atlanta where we don't really have grocery stores, where people are getting a lot of their food from like corner markets like this one here, where you can see it's like bread, milk, soda, beer. There's not a very large fresh food selection. So knowing, you know, where people are actually getting food, and then helping them expand their what they think is possible, particularly in places where there's public transportation and it costs the same to get on the train or to walk, you know, to get on the train to go one stop as it does to like transfer and go to the big farmers market where the food is actually cheaper. You know, that can be really helpful, but can also, again, make things very specific to a person, what they're capable of and what their circumstances are. What is your food budget? I sit down with pen and paper with a lot of, I see some nodding from Anne, with my patients. Like, it's, you know, you're like, oh, I'm an internist in primary care. Let's do a food budget. Like, I love food. I can help you. Like, I've eaten on a residence budget. Yes, it is not the same as, by all means, it is not the same as someone who is living on like Social Security disability in terms of the fixed income and SNAP benefits, subsidized nutritional assistance program. But it's important to know what's your budget, you know, how much money do you have for food and where are you spending this money? So I looked this up because in Georgia, we have SNAP matching at a number of our farmers markets. And that also occurs in Washington state as well. I just realized today that y'all are in other states too, but you can look it up. It means that the dollar can stretch a little further to get fresh fruits and vegetables. Again, these are not going to be the cheapest places to shop, so that's something to keep in mind as well. But you do get a little bit of extra value for your dollar. Salvage grocery stores can be a very good option. So those are places where things that are lightly expired or unused or blemished in some ways, and grocery stores go. Again, I just looked up the one for Washington, but they're across the United States. Stores like Dollar Tree often have frozen foods in the back, and while a lot of those are processed foods, they may have things like frozen chicken breasts or vegetables for 99 cents. And so that can be a really good thing for you to help your patients with. Food banks, I have a whole list. Like if you have people who work with you, like residents, like I had a resident whose whole project was to visit food banks and find out when they got fresh food and then fresh fruits and vegetables, and then come up with a whole resource list that I have as a dot phrase, and I can put it right into the discharge instructions when patients come to my clinic. So really knowing like how much money people have and how to help them find healthy foods. Gosh, I'm gonna look at time because I know I'm gonna go over. I have a feeling. Okay, yeah, I'll move it along. Okay. Fast food is a big part of a lot of the lives of my patients. I, again, don't have any like money coming in from any specific fast food industry. I tried to look up, a lot of my patients eat at McDonald's, and I tried to look up like healthy McDonald's meals, and there's no vegetables at McDonald's, as far as I can tell from the menu I looked up online. But Subway definitely has real vegetables. So, helping your patients think about, okay, so how much does that meal cost? If you're gonna go to McDonald's, what are you ordering? Can you get like a water instead of a large soda? The low-hanging fruit for me is always the drinks. I don't know if your group home owners are serving your patients all like the biggest bottles of Kool-Aid in the entire universe, but that's like everyone I meet. I'm like, well, how do they get sweetener? And they're like, oh no, we've got like a huge bag of sugar that they're just like pouring into this. So if you can talk to people, I've had more than one patient, I don't know where this came up, but that if you drink clear drinks, there's no calories in them. So like Sprite, but no, clearly that's not true. And so sometimes some education there. And like, I might be using this in some ways, but like a lot of my patients and I talk about how much like the advertising industry wants to trick them, like to spend their money, and like they'll say like, oh, juice is healthy, but like it has so much sugar and so many calories in it. So they like it. It helps some of my patients, I think, to feel like we're working against this other enemy, which is bad health, together, to figure out like what is the true best way going forward. Okay, when all else fails, portion control can be helpful. The small plate, there's like not a lot of data that eating off the small plate really changes anything. I was just reading that when I was preparing these slides. However, if your patient is getting seconds or thirds, definitely just the one plate can be helpful. Mindful eating, I think, is just a really beautiful message for people to live a better life. I can't tell you how many patients eat in front of their TV for every single meal. And I think it's really robbing people of the chance for community, even to if they are living with people that they don't commonly find a lot of kinship with, or a lot of like friendly interplay with, that it might be an opportunity for them to like meet someone new or have a new friend. I don't focus on a ton of these things. The main ones that I feel like I focus on most of the time are sit at a real table and don't watch TV or get on any sort of device while you're eating. Okay. Increasing physical activity. This does not look like where my patients live. So I put this picture up just a little bit ironically. A lot of people that I treat don't feel comfortable leaving their homes at certain hours. That also is important in food planning. When we talk about food planning, I think people who live in neighborhoods where if like they can't go to the corner store between like 7 and 10 p.m. because of gang activity, like we've got to work around that realistically. So, you know, getting into that nitty gritty again, like you're going to people's houses, so you can say like, show me what shoes you wear when you exercise. What are you going to put on your body, like that's comfortable and appropriate, like that you feel comfortable in. Let's have a walking meeting. Like, can we go walk around the block while we talk about how you're doing? Anything that you can do to make physical activity realistic. Yeah, getting them partners is a huge thing. Accountability partners is a great thing. And I mean, I feel like all of us have a hard time with this. So definitely using whatever tools you can from your own experience in your own life to improve the lives of your patients. That's a good idea. Smoking could be like 10 lectures, in my opinion. I think it's so interesting. I used to be a smoker when I was in high school because I thought it was cool. I smoked a pack of cigarettes a day and got kicked out of the National Honor Society. It was a whole scandal. Fortunately, I was able to quit, but it's a hard thing to do. Talking about smoking is a whole nother thing. When I do motivational interviewing, I think one thing that I would recommend is talking about the cost of cigarettes, like how crazy expensive cigarettes are and what could people do with that money. Because even if people really can't think of any other reason to quit smoking, most people don't want to be spending $7 or whatever it costs to buy a pack of like brand name cigarettes. So counseling and medications have been shown to be better than either one alone. Either one alone is better than doing nothing at all. So definitely if you're talking to your patients about smoking and if they have any desire to cut back or quit, that is an excellent conversation. Nicotine replacement therapy is often free from quit lines. It is in the state of Georgia. So if you want to look that up for your own local area, that's a pretty awesome resource. And then they harass people too and just keep calling them and being like, have you quit smoking? You want to talk about it? You all who are the prescribers on the line are familiar with Wellbutrin from your mental health work. It has greater efficacy when combined with nicotine replacement therapy. You can use both. Oh, taking a step back, there used to be this old wisdom that you can't smoke and put on a nicotine patch or chew the nicotine gum. You absolutely can. It is totally safe. The goal is to use the nicotine replacement and try to cut back as much as you can on smoking. Varenicline or Chantix and the newest medication, cytisinicline, are partial nicotine agonists, antagonists. They don't really work with nicotine replacement therapy, so it doesn't really make sense to double that up. But they are generally seen as the most efficacious. They used to have a black box warning about mood changes. The black box warning has been removed, or suicidality, but they can. There is some evidence that there is an increased risk of patients having adverse mood, potentially suicidality. So it's something you want to talk to your patients about and consider. It's not a reason not to have them not use the medication if it's available to you. And it's very easy to prescribe. There's like a starter pack. So all you have to write for is like Chantix starter pack. GI upset occurs, there is a titration schedule. So just keep that in mind. Okay. Let's take like 3 minutes for a patient role play, and then we're going to go on to diagnosis and treatment of some cardiovascular associated conditions. Does anyone in our audience want to pretend to be a patient, and I can counsel you on some sort of risk, cardiovascular associated risk behavior? I can't see if we have volunteers, so I'm going to depend on our moderators.
I haven't seen anything.
Okay.
Let's see. Anybody?
Anyone?
We might be back
I'll
to you.
do it if nobody else wants to. I mean, I don't have to be the one, but if nobody else will do it, I will.
Oh,
I
we got
like
somebody. We also have somebody who
good.
raised their hand.
Let her do
So
that. Yes, let her
you
do
want-
that. Yes.
Okay.
Yes.
Adoranke, if I'm saying your name correctly. Omatade.
Yes, you are.
Okay.
Do you want me on camera or does it matter?
It doesn't matter. Yeah,
on
whatever
camera.
you're comfortable with. Okay, so I'm your ACT provider. I'm your ACT provider, either one. And why don't you tell me? I've just come to your house, and I'm gonna say like, okay, so tell me a little bit about any health concerns you might have.
Yeah, so I was just at my doctor's. He was saying something about like that sugar stuff. And
Okay.
I don't think it's true because, like God is going to take care of me. So like that's never going to be a problem for me.
Okay. Well, I hear a few things. So it's great that you went to see your doctor. I'm also really glad to hear that your spirituality seems like it's something that's been really helpful to you in terms of dealing with life. Yeah. But I also hear you saying something about sugar. So what did you hear from your doctor about sugar?
He said like, I think he said my sugar was a little bit was high.
Mm-hmm.
But I don't think it's true because you know how they always say something's wrong with you. So I don't think it's true.
Yes, like that. It seems sometimes like that's like it is their job in some ways, but it is also like, it seems like you're always getting bad news, right? Okay. So, do you know what that means in terms of like your sugar being high? Do you have an understanding of what he's talking about? Or he or she, or
so
they?
It's a he, but I think
Okay.
like I feel fine. So like
Yeah.
I don't think, so that's why I know it's not really true because I don't I feel okay.
Gotcha.
There's nothing wrong with me.
I gotcha. Okay. So you've been feeling fine, but your doctor was telling you that you had higher sugar.
Yes.
Okay. Have you known anyone in your family who's had high sugar before?
My father.
Your dad did. Okay.
Yeah, my sister too.
Oh gosh. Okay. So you've known a few people who've had this problem.
Yes.
Yeah. Yeah. How do you feel about, or what did you see or feel about their having high sugar?
I don't think it was a problem for them. Like they other things happened,
I see. Okay.
Yeah, it wasn't a problem for them. The doctors, they kept on trying to make them take that shot.
Oh,
and
okay.
I never want to take a shot. Like they keep trying to get them to take it. And they didn't
Needles
like
can
it.
be
It was
scary.
painful.
It hurt. Okay, so that's something that you saw, is that they were in pain and that someone was trying to force them to do something they didn't want to do.
Mm-hmm.
Yeah. Does that sound right?
No, it doesn't
Oh, I
sound good
mean,
at all. Oh, yes, I'm sorry.
am I understanding you correctly? No, that's
Yes,
quite all right. Am I understanding you? Okay.
yes.
Okay. Well, I'm going to stop us in our conversation, but I hope that gives you all a flavor of like maybe how motivational interviewing goes. It is very not, I mean, you can see I'm working towards a goal, right? But a lot of it is just me trying to understand her worldview and to see what any motivations, fears, her understanding, her buy-in, and both the information she's gotten as well as her belief in me, that I'm listening to her and that I'm on her side. Yeah, without me trying to villainize her primary care doctor. I felt a little bad when I was like, it's their job, but it does seem like they're trying to tell you what to do. Okay. So hopefully that gave you all just a little flavor of what motivational interviewing can be like. And it's pretty fun. I mean, it's just nice to try to understand what's going on inside of people's lives. And I would guess that's a big motivator for being ACT team members. Okay, so moving on, we're going to talk a little bit about prescribing and pharmacology. And first, I just wanted to talk about specific medications that our patients take and the risk of cardiovascular problems. We don't really use metabolic syndrome as much anymore, but this is an older paper from, I guess, from 2021, but still, this allows us to see some of these risk factors. And as you can see here, the risk profile does follow along with the pharmacology of the different medications and primarily in terms of which receptors they bind to and antagonize. So the serotonin 2C receptor, the histaminergic receptor, and the muscarinic receptors in the periphery, the M3 receptors, the 5-HT2C and H1 receptors promote hunger, so they can cause weight gain. And then the muscarinic receptors work on those pancreatic islet cells, so they decrease insulin secretion. And then they also can increase glucose metabolism. Sorry, I just heard my dog destroying a door. It's raining hard here. Okay, so if you look, these are things we know. So clozapine and olanzapine, the peen drugs with very good efficacy in general, also have high antagonism of these receptors and have high risk for metabolic problems. We've got our medium risk medications, risperidone, paliperidone, quetiapine, and asenapine. And then we've got our lower risk medications, which include some medications that I don't generally have in the medications I prescribe because of what's covered by our drug formulary for patients who are uninsured, underinsured, or insured by Medicare and Medicaid. So, it's something to know in terms of looking out for what could happen if individuals are taking different medications. There's some evidence for adding other medications to atypicals when metabolic problems are happening. There's decent evidence for adding aripiprazole, more robust evidence for adding metformin, and this is solely for antipsychotic associated metabolic conditions, including weight gain, not for glucose, not simply for prediabetes or diabetes. So you can use metformin to treat weight gain in patients. You can use it to treat weight gain in patients who have severe mental illness, regardless of whether they're taking atypical antipsychotics, but there's a good evidence base for using it in individuals who take atypicals. Switching antipsychotics can feel like the shell game for patients, which is one reason why when we look at studies of switching, we see a high rate of discontinuation of medications if patients end up switching antipsychotics. But there is an improvement in metabolic parameters, and for the majority of these studies, it's when switching from one of those pain medications, so olanzapine, clozapine, to amisulpride, aripiprazole, lurasidone, ziprasidone. And you can see that the data is greatest for aripiprazole and ziprasidone. Interestingly enough, in these studies, they saw no deterioration in psychotic symptoms, which is always a surprise to me. I think these patients must be very carefully chosen because in my experience, it's a risk. Like, people are on medications and they're stable for years. I would take a big, long minute to think about switching them to another medication. But again, high discontinuation rates, which could lead to decompensation. So, you know, if I have a patient who's taking clozapine and they're gaining weight, am I going to switch them to like the ziprasidone? The answer is I am not. But that's just my 2 cents. We know other psychotropics bind to some of these receptors and antagonize them. Among antidepressants, the tricyclics, which we rarely use primarily to treat depression anymore, but which your patients may be taking for other problems, have shown the greatest weight gain. However, SSRIs are also associated with weight gain, with citalopram in the lead, probably because of the anticholinergic effects. Among the mood stabilizers, valproic acid is associated with the greatest weight gain, although lithium is also associated with some weight gain. Fosphenytoin isn't really used as a mood stabilizer, but if you're seeing people who are on other anticonvulsants and they're on fosphenytoin, that's definitely one that causes metabolic changes. Okay, so thinking about those receptor profiles, and you're seeing patients who are having tremor, you may want to think more about immediately putting them on anticholinergic medications, which have moderate efficacy for like tardive dyskinesia and other movement symptoms. But at least here in the state of Georgia, we see tons of patients who come in on benztropine, and we can see that it is associated with at least dry mouth, and patients are drinking things to combat that dry mouth. But the sedating effects of some of our medications as well can really inhibit patients from having, like, they get up and go to start a physical activity routine or even just cook a meal for themselves. So something to think about there. Okay, I'm gonna wrap this up with a few words about diagnosis and treatment of hypertension, diabetes, and dyslipidemia. I did take out my slides on obesity because I, again, think that could be its own talk, but just know that if a patient has a BMI of 25 to 30, they're overweight, greater than 30, they have obesity. If they have a BMI greater than 35 and a major comorbidity, they are eligible through insurance to get bariatric surgery. If they have a BMI greater than 40, then they are also eligible for bariatric surgery. I've seen bariatric surgery as a life-giving operation in a number of people. It should be carefully considered because there are psychological changes that occur with bariatric surgery. And I think there are studies that look at safety in individuals with SMI, and it's been seen to be safe, but I think it's a much bigger conversation. I just want you to keep it in your mind as something that, just like the general population, it's complex, but can really improve both the quality and quantity of someone's life who's suffering from a lot of cardiovascular risk factors. Okay. We are largely familiar with this. This is the 2004 APA/ADA guidelines for screening. You should be screening and anyone any typical antipsychotics at baseline, and then at a minimum, really of like 12 weeks for all of these, at least when you first start them, annually, if everything is normal and there's no other risk factors. So more frequently in people who have risk on atypicals. For the rest of the population not taking atypicals, the recommendations for lipid screening is once at age 20. And then for those at higher risk, which for the purposes of the rest of this conversation, I am going to just suggest that our patients are high risk who have serious mental illness, regardless of comorbidity, just because of the number, just the rapidity of atherosclerotic disease progression in this population, which has a lot to do with many things, but inflammation, chronic inflammation from this disease, from these diseases is one thing that contributes greatly. So that would be men, like basically every 5 years. So if you don't see ASCVD, so at 20 and then about every 5 years. For hypertension, if it increased risk when they become adults and then annually, these are Black, overweight, or obese. Those are the recommendations for who qualifies for higher risk. Hypertension screening does not require a blood draw. So I would say if you can check their blood pressure anytime you're out at their place, go for it. Diabetes screening, age 45 or age 18 if overweight or obese, and that's every 3 years if it's normal. That should be if is normal, but every 6 to 12 months if you have any abnormalities. So that means if you have someone who's 18 who's even overweight, you should be checking, and they're not, even if they're not on atypical antipsychotics, you should be checking their blood glucose or some sort of equivalent every 6 to 12 months. So basically, when your patients are adults, check their lipids, blood pressure, and blood glucose. Probably this shouldn't be every, well, if normal, like at a minimum every 5 years for lipids, annually for blood pressure, and every 3 years for blood glucose. Okay, just a word on treatment before we go on and some very brief recommendations for treatment. If you can make friends with a primary care doctor who you trust to treat your patients with dignity and respect, and who is willing to give you their cell phone number so that you can like just text them if you have a quick question, they can be your partner in prescribing. I do this for a lot of people, and it's not a big deal. Like it takes 2 seconds. And if you find someone who really cares about changing the health of the patients, about this specific population, they will be your ally, and you will be doing an amazing service for the patients, the clients, the people that we see who suffer pretty severely from the effects of these cardiovascular related conditions. Even if somebody doesn't want to give you their cell number, or if you have somebody who is not, who understands enough about psychosis to have respect and curiosity for the lives that people live, that's a really great thing. I did not find many people in my internal medicine side of my residency program who wanted to treat patients with psychosis. So it's a good thing if you find one to get in there with them. Okay. Getting labs. So you don't have to get fasting labs when you get a lipid panel. I just want you to know that. Because a lot of times it's hard to get fasting labs. Like people are going to eat when they're going to eat. The only things that change when you eat are triglycerides and LDL. When you're calculating risk, LDL is approximately equal to total cholesterol minus HDL minus 30. It's a lot of like math to deal with in like a 1 second slide. So look at this later, but just so you know, you can calculate an LDL equivalent if you get non-fasting labs. And that's important because treatment with statins depends on reducing cardiovascular risk through reducing LDL. I'm not going to go through this a lot because I just want you to know that people who have diabetes, okay, so there's a risk calculator. and you can get it at this website, or you can just Google ASCVD risk. You put in all of this information, and it gives you a 10-year risk of having an atherosclerotic cardiovascular disease event, an ASCVD event. If somebody has a risk of greater than 7.5, they all should be on a statin. If somebody has diabetes, they should be on a statin. If they're over 75 years of age, they should not be on a statin. That's what I want to tell you. Statins are pretty well tolerated. I'm not going to go through all this, but moderate intensity is a good way to go. So if you want to do a torvastatin, 10 milligrams for anyone who has an ASCVD risk greater than 7.5%, you're in a good place. Okay, that's all I'm going to say on that. And then there's more about monitoring. You really monitor for efficacy and adherence rather than for any adverse effects. So you don't need to do lab monitoring in patients that you start on a statin in terms of safety. Some people get myalgias. True myositis is incredibly rare. If somebody's hurting a lot, stop the medication and check a CK. If somebody is having just a little bit of muscle ache, you can decrease the dose and they should probably be okay, or you can switch to a lower potency statin. Diagnosing diabetes, so sugar dysregulation occurs in a range on a continuum. So there's normal, there's pre-diabetes, and then there's diabetes. You can see that an A1C greater than 6.5 is diabetes and A1C less than 5.7 is normal. I would treat people with pre-diabetes with metformin. I would treat people with diabetes with metformin. Metformin's first line for the treatment of type 2 diabetes. You can start it at 500 Q-day to BID. Your goal is to get to the highest tolerated dose of 1,000 milligrams BID. People usually get GI side effects. They go away. So you got to tell them, you're probably going to have diarrhea. You might have some cramping. It's probably going to get better in a week. If it doesn't get better in a week, I want you to call me, or you'll be visiting them. But just having patients know that it's to be expected and it goes away often means they'll stick with the medication. Metformin can be used, as I had stated, for antipsychotic associated weight gain, even if there isn't glucose dysregulation. Hypertension, blood pressure greater than 130 or 80 on 3 or more readings that are usually within the course of weeks to months. This slide just shows you what the current recommendations are for the treatment of hypertension based on whether chronic kidney disease or no kidney disease is present and whether your patients are Black or not. And the only difference here is that if they don't have chronic kidney disease and they are Black, then if you have them on an ACE inhibitor or an angiotensin receptor blocker alone, there is higher mortality. So you do want to start with a thiazide type diuretic or a calcium channel blocker. This may not be as relevant as though you can see, because you can see here for lab monitoring, calcium channel blockers, you don't have to monitor labs. So it can be challenging if patients have intermittent adherence to, or you don't really know what's going on in terms of them taking the medicine. Do they start it? Do they stop it? Because you do have to check like, potassium and sodium. You have to check electrolytes and creatinine when you start thiazide diuretics or ACE inhibitors. And then like every 3 months to make sure you're not causing a hypo or hyperkalemia and any like creatinine changes. And so, you know, it's usually just a lot easier if someone needs a single agent to do a calcium channel blocker. Amlodipine 5 milligrams, you can increase it to 10 milligrams. Okay. And in summary, cardiovascular and SMI, they're good friends. People with SMI die from cardiovascular disease much too often and much too early. We can change it. Motivational interviewing helps everyone, including us as providers. If you have metabolic problems, consider subtracting things anytime you can, lower dose, less medication, adding something or switching, although please do not do not do this willy-nilly, because I know you're not going to, but it's hard for patients to lose what they've gained on medications, including trust and stability. Screen lipids, blood pressure, and blood glucose in adults starting basically when they're 18. Make friends with a primary care doctor. Statins, metformin, and amlodipine are fairly easy to prescribe. And then I just put this up as a reminder because peonies are my favorite flower. Buy yourself some flowers, or at the very minimum, do something nice for yourselves. This is hard work, and your patients need you to stick with it. Thank you for your attention. Happy to take questions, comments.
Yeah. Martha, thank you very much. And I did want to make sure, you know, I know you were trying to get through things quickly, and I know you were sensitive to the fact that we were trying to also balance this with some general questions about ACT and the role of the psychiatric care provider, not just focusing on your topic, but on other topics. That said, I did want to make sure that as people, you know, there were some areas that you did have to kind of go through rather quickly, particularly in the area of statins. And I wanted to make sure if people have questions about those areas, that if you needed to go back to those slides,
I'm happy to.
Felt like, so anything at all that folks want to make sure Martha covers more, or if you have specific questions, please feel free to raise your hand or put the question in the Q&A box, anything like that at all. And we did get some questions about, will the slides be available? And we'll have them on our website. I'm going to find the link here in a second to post that. And the recording will also be available. We did get a question. Can you please talk about the relationship between, I think it's statin and antidepressants, any evidence of improved efficacy? It says between stating and antidepressants. And if the person who asked that question, I don't know if it's a typo, talk about the relationship between
I don't know that. So if someone else has information, I would be very interested in hearing about it.
Okay. Does it make sense? It's probably statin and antidepressants. Okay.
Yeah, seems like it.
Yeah. Anybody have any thoughts about that or comments?
I've never heard of that.
Okay. Okay. Other thoughts or other questions folks have? And by the way, Peyton did put the slides up, so you should have access to those, and we'll get the recording up too.
I quickly Googled it. There's an NIH paper about statins and antidepressants. It's a comprehensive review. So I don't want to speak about anything that I don't know about, but there is a paper out there. And I would guess that some of it is through the anti-inflammatory effects of statins.
Okay. That makes sense. Kimberly, you got a question? You just have to unmute.
Yeah,
There you go.
I did. Well, I know how to unmute. I didn't know how to raise my hand till just now. I just figured that out. So I'll be doing that now. But I was just, as a mental health nurse practitioner, I typically don't prescribe medical medications. Now I have done metformin for when I had clozapine, but we're getting into the higher level lipids and you know, hypertension medication. I just refer them back to their PCP. So I just was curious as to what others do. You know, do they take on that role, or do they kind of let the ones, you know, I don't mind some metformin, but I don't want to go too far.
Yeah, I mean, it's easy for me to say go ahead and do it because
but you're dual certified, so I'm sure you do it all the time.
Medicine. So I'd love to hear from other people.
Yeah, I would too. I'd like to hear from teachers that are only, you know, mental health providers, what they're doing for things like hypertension and hyperlipidemia.
Steve or Ann, do you have any thoughts on that? And I'd love to hear from our broader group if others wanted to share too. I know it's hard. I mean, this is exactly the crux, right, of this intersection is tricky with ACT.
I remember Eric Vanderlip back in the day was very encouraging of psychiatrists dipping their toes in these waters, and prescribing, basic things like that when there's no other options. I know, and I've had a few people with really high blood pressure, like 200 over 100 something, and we found out about a health fair, so didn't want it too paranoid to go to a primary care doctor, so I started lisinopril. So there's cases like those where it's clearly not even it's bordering on not safe not to do anything, and they're not going to go anywhere else. Sometimes too, if you get, like in this case, get good results with it, they see the progress, then suddenly they're less paranoid, and then we switch them to primary care because they felt good about what they had done. So I think it's sort of in a situation like that where you're bridging something, and then trying to move them into primary care after that.
I would agree. Actually, Steve, it's one of the nice things about working with third-year residents is they're much closer to prescribing these things and being trained in prescribing them than we are. So it's one of the benefits of that educational relationship. I, for many years, had a friend who was double boarded in emergency medicine and internal medicine, who was my go-to on this. And in recent years, we have had a family medicine nurse practitioner embedded in our division of community psychiatry for reverse integrated care. I realize this is Disneyland, relatively speaking, but it's been amazing.
We also got a comment in the Q&A. Eileen Schwartz mentioned that they have an associated FQHC for primary care, and so they prefer that they leave it to them. And I know that has been the case with some of these like integrated, co-located, public health clinics that are within the behavioral health clinic or FQHCs, that can be the case. But your question, I'm assuming, comes from the fact that that's not the case for you, Kimberly. So knowing where people are drawing that line. Anyone else want to comment on like how you're managing that, or where you draw the line for yourselves in this regard? Or feel free to put it into the chat just to share out with one another. In the meantime, while we're waiting, there are some other questions that I thought we could get to. A question about how about the challenge of encouraging blood sugar monitoring for type 2 diabetes?
Yeah, that's a hard one. So I have patients who use insulin who have a hard time monitoring their blood glucose, and that's scary. So what I try to do, so you don't need to monitor your blood glucose as frequently if you're on oral medications. So I try to aim for like once a day if I can, for even patients who take insulin. So, and then at different times a day, both fasting and after a meal. And then I usually give them like a handwritten out chart that I have that's like, what time was it? When did I eat? What was my sugar? So that is the advice that I have. I mean, I'm not very good at using those machines, but I do have them bring them in. So if you can have someone who knows how to use them go out to their house, so you're ensuring that they understand how to use the equipment, and that it's working. Like they break, they need new batteries. It's a whole thing. I think that at least our insurers will pay for one machine per year. I have sadly paid out of pocket for other people at times because it's worth it to me that they check their sugar. Yeah.
What about
But
glucose monitors? Like, do you find that people get, Dexcoms or, other kinds of glucose monitors? No, does that?
We
Yeah.
we like continuous glucose
Yeah,
monitoring.
yeah.
We don't have very much access to that in the
Okay.
patients. I mean, we have access. Patients won't go to the diabetes clinic, or yes, they are
Okay.
like, I don't want to go to the diabetes clinic, but I'd love to hear if anybody else has any.
Yeah, we have 3 people that are wearing the monitors, and um it was a long struggle. It took a lot of consistent time to figure out how to keep it on their body. That took a lot of work on the part of my psych resident and a nurse. And then keeping their phones charged so that they can get the results is the other big one. But it has been helpful with the few people that we are able to keep it on. Even one of them who's quite marginally, always kind of a little homeless and not doing well. He's now in the habit of checking after us harassing him for 3 or 4 years. So
Awesome. I mean, the
And
feedback that people can get too.
right.
It's like I just had a honey bun and now my sugar is 378. Like it is amazing.
Yeah. The other thing we've seen in some teams is, the nurse or the prescriber orienting the client or doing education around using the finger poke and doing their own, but then other team members getting trained by the prescriber or by the nurses and how to at least encourage it, and prompting around and knowing what the numbers may mean. And it's not that they're going out of scope of practice kinds of things, but rather they're helping the person to kind of self-monitor. So it doesn't, so during their regular time, they might be showing up to do integrated treatment for co-occurring substance use, and yet they can say, hey, let's take a look at your blood sugar. So why don't you pull out, your glucose monitor and something like that. So a couple of other questions. What would you recommend, or would you recommend, I should say, Ozempic or other similar drugs for patients with diabetes who are overweight or obese?
Yeah. So Steve and I were talking a little bit about that before we started the webinar. Absolutely. So with a few caveats. Those are great medications in terms of improving glucose control. And decreasing insulin requirements, and they're weekly in terms of their administration. So for patients who are afraid of insulin, because of all of the risk of hypoglycemia and all the injections, and it can be like a compromise sadly on the road to insulin for some people. The challenge that I've come across is that now that those medications are being marketed and used for weight loss alone, we have not been able to consistently source them. And so we have the challenge of patients not being able to get medications, and then they get them some of the time, and then what do we do when they can't get them, or then they do get them and then they're on a higher dose of insulin, and so it can be really hard. I mean, I think they work great for blood glucose control. I haven't seen the same result that we see in the general population in terms of weight. And I think I've hypothesized there are a number of reasons for that it's a complex relationship between severe mental illness, mainly psychotic illnesses, and weight gain, with a lot of it related to medication receptor antagonism that doesn't change if you're on a medication, decreased ability to attend to some of the somatic symptoms associated with satiety, just lack of social networks, lack of some of the other pieces that gate food intake for some of the people who are finding weight loss with the GLP-1 medications.
This is where I'm going to show my lack of expertise. Is Lybalvi the same kind of medication? Because there was a question
No,
about that. Okay. That's another
yeah,
question then, I guess, is there any
yeah.
experience with switching to Lybalvi for weight gain?
So that is not something that's available to my patients. I know that it is it's olanzapine plus or opioid antagonist. So that has been shown to offset some of the weight gain associated with olanzapine use alone. I don't personally have access to that medication. Yeah, I mean, I think that the change that you're going to get from like the absolute change in weight that you're going to get and the change in like overall outcomes that you would get from switching from olanzapine to olanzapine samidorphan isn't the same as like the conceptualization that I have about like changing the way someone feels about themselves and their habits in life. Yeah, that would be like my philosophy, but it also is not based on practical use of that medication. So I mean, I know what the data says, I just don't know what the actual like anecdotal effects of that medicine is.
Anybody else? Does anybody else have any comment on that? Just, I know we're kind of at time, but I want to make sure if there are any other questions. We've got 2 more questions in here. Do we have time for 2 more questions?
I'm
For those who
fine
can
if
stay in? Okay. Okay, so one of the 2 is if, oh shoot, I just lost it. Okay, can you comment on statins for younger patients? So a risk
yeah,
calculator starts at 40,
right.
but they have younger
So
patients. Yeah.
yeah, so the risk calculator starts at age 40. However, that is for anyone who has an LDL less than a fasting LDL less than 190. So you're going to have a population who go outside of the risk calculator. Anyone who has an LDL greater than 190, a fasting LDL greater than 190. So if you use the equation, that's non-HDL cholesterol minus 30 of greater than 190 should be on a statin to lower LDL. I generally follow those guidelines for our patients with serious mental illness because I mean, so risk benefit for statins also, there isn't a consistently convincing link between statins and diabetes or statins and dementia, but those things have come up in studies. So there is some concern for risk benefit. We're looking more at like 10-year risk. So if someone doesn't have like a hugely elevated cholesterol, I would be more likely to focus on other comorbid cardiovascular risk factors than to necessarily add a statin for someone who has an LDL less than 190, who's less than 40 years of age.
Thank you. One last question, and this may be a broader question. Anne and Steve, you might have some thoughts on this or others on the call. And this is just, I think this could easily apply to lots of different areas of medical challenges. Can someone speak to the liability of ACT in regard to clients who refuse primary care with uncontrolled hypertension? Any thoughts on that?
Yeah, I think that gets right to the heart that, ACT is considered a focus point of responsibility for someone's broad-based life, care, everything in it. So, and in a lot of things are refused by people that put higher risk. So this is one thing of many, but I think this is a good example of when you would get your psychiatric care provider to consider directly treating it yourself as an ACT team.
I would agree completely. And, then just thorough documentation of what you're doing and why you're doing it. like I said, long time since I learned antihypertensives, but I beat the heck out of not getting any.
Where does the legal, just knowing that liability was the question too?
I think that's where the documentation comes in. We have moved heaven and earth trying to get this person to see a primary care provider. There have been occasions when someone has had a very psychotic reason for not seeing primary care. They're in a life-threatening situation, and I have invoked involuntary hospitalization simply for assessment in the way that I can do that in the state of Maryland. But in general, we have to make our best decisions. We want to discuss those with colleagues, and there's liability in anything we do there.
And that's the grave disability, probably meeting the criteria, or danger to self potentially. Martha? Yeah.
So I think Anne made an important point there, and that it needs to be because of mental illness. So like I have patients who are like, I don't want to take that medicine because I don't like taking medication. And they're not like, oh, I'll use the example of the person that was like, someone's putting something in my insulin. And I was like, you're going to the hospital. And unfortunately, I'm going to have to involuntarily commit you. That's very different from the person who's like, I just didn't feel like it. That's a terrible reason, but and yes, there is some relation to a motivation, but it is not something that that person has autonomy to make that decision. And I think as long as you're documenting that, the discussion was had. Yeah.
Thank you so much. I'm going to end us 6 minutes over the time, but really appreciate you being here with us, Martha and
Thank you,
Anne
guys.
and Steve and everyone on the call today. So I hope that you will join us on August 15th, and we'll look forward to talking more about co-occurring substance use disorder and using harm reduction techniques, and focusing a lot on kind of the age of fentanyl and how that's made a lot of challenges related to using harm reduction. So we'll look forward to seeing you then, and have a wonderful rest of your summer in the meantime. Hope everyone can stay cool and also out of the thunderstorms and hurricanes and all those other things you get in the deep South, Martha, and others. Take care, everyone. Thanks for joining
Thanks,
us.
everybody. I
Bye-bye.
appreciate it.